All right. So starting the recording, thank you for joining us today. Our presentation on Medicaid in Oregon and the vital role of WIC nutritionists is ready to begin. As mentioned, this session is being recorded and will be posted to the WIC website, and the presentation will provide 1.5 units of continuing education. Objectives for today's presentation will start with providing background and context, describing the evolution of Medicaid in Oregon, including the origin of coordinated care organizations and how Oregon, and a fun fact, Oregon is the last state in the nation to fully implement early and periodic screening, diagnostic, and treatment known as EPSDT. We'll cover how EPSDT impacts nutrition services, including medical formulas. And we're being joined today by Ellen Pinney, who will orient us to the role of the Ombuds team in advocating for our shared families. We'll look at a recent case study. It's a success story with the help from the Ombuds team. And we hope to have a discussion of opportunities for change within the Oregon Health Authority and WIC. Please know that the content is pretty acronym heavy with lots of jargon. Please have patience with yourself and with others as we learn this new language. All questions, comments are welcomed and encouraged. If you're not clear or sure, others are likely to be in a similar situation, and we really appreciate any clarifying questions. So I've seen in the chat that we're sharing out your name, where you work, the agency, and then your CCOs. And if you don't know the name of your CCO, that's totally fine. That helps us understand where everyone's coming from. On the flip side, if your organization has been doing some innovative work with the CCOs, we would like to hear about that as well. So, Joan, can you confirm that we are recording?
I saw the little message come up.
Okay,
that the
good.
recording was in progress.
Thank you.
I'm sorry, my thing went everywhere and I couldn't quite find it.
No worries, no worries. I didn't mean to put you on the spot. All right. All right. First, I want to ground this work and this presentation in a deep gratitude for WIC and then WIC staff. The more that I've learned about gaps and barriers and challenges in this collaboration between WIC and our colleagues on the Medicaid side, the more I really appreciate how WIC has stepped in to protect and serve our shared families. I sincerely have the utmost respect and for the dedication, support, and compassion that all of you have provided WIC participants and their families. We have several guests with us today, and Ellen Pinney will be our guest speaker, providing her expertise related to OHP and the Ombuds team. And Ellen will be introducing guests, including those that we have from the Health Systems Division, both in the Client Services Unit and the policy leads, as well as our innovator agents. I also want to call out that I believe I saw some of our colleagues from Aviana, from the durable medical equipment vendor that helps provide a critical role of tubes, feeding supplies, and formula for our shared participants, as well as oral supplements. So there will be more discussion about that as we go through. I'm hoping that we see more. I don't know if Jennifer, her colleague Jennifer Saunders, is also joining us today. I sure hope so. But as we go through, there'll be more introductions to come. So as we go through during the discussion, we look forward to your contributions. Please raise your hand or chat, put things in the chat. We have built-in slides into the presentation for questions and input as we go along. So For now, Ellen, I'll pass it over to you to introduce yourself and provide us with a foundation in the evolution of Oregon Health Plan, and I'm happy to advance your slides as needed.
Thank you. Thank you for queuing me up, Cheryl. And, you know, this is like an all-day presentation, so we forgot to tell you that piece. I'm just joking a little bit here. Oregon Health Plan is Oregon's program that provides Medicaid services to folks who qualify for Medicaid and the Oregon Health Plan. Oregon Health Plan is kind of the full package. When we talk about it, we think about the full package of benefits that Medicaid clients receive. 1.4 million, probably down a little now, but a third to a quarter of the state enrolled in Oregon's Medicaid program. 1 in 10 of those folks is now in a coordinated care organization. 1 out of 10 of those folks, or 1/10, is enrolled in fee-for-service, meaning the state pays for their health care directly. Oregon Health Plan was launched by then Senate President John Kitzhaber in 1989 and formally kind of sprung free, I think, in 1993. The goal of the Oregon Health Plan, as intended, there was this triple aim. It still guides our agency: improve health, improve patient experience, and lower healthcare costs. The next slide, please. Oregon Health Plan expanded in 2009 to cover uninsured children. This was in large part due to Obamacare, and in fact, the Affordable Care Act raised the income threshold for Medicaid across the board to any state that wanted to take advantage of the incredibly strong financial incentive we were all given to rise to the occasion and cover children up to 300% of the federal poverty level and adults up to 135% of the federal poverty level. We also launched at that time coordinated care organizations, which in my opinion are otherwise known as insurance plans. But the big difference between a coordinated care organization and a conventional insurance product is that CCOs are supposed to be coordinating care. They provide care coordinators specifically for high risk and populations who might need care coordination because they have a multiple of different physical, mental, or dental issues that they're dealing with. And just this year, Oregon finally eliminated the waiver we had requested a long time ago, saying, yeah, we believe in early periodic screening and diagnosis, but because we have this prioritized list of services, we can't guarantee that we're going to provide treatment for all of the screenings that might have showed up in diagnostic tests. So in 2023, we said, we're done. We are going to join the rest of the nation. We are going to provide EPS, early periodic screening, diagnosis, and treatment to all children along a continuum, which I believe Cheryl's provided a link for what EPSDT provides now and who gets coverage and what that coverage looks like. And here I'm going to turn over this slide to my colleague. I'm an ombuds with the Oregon Health Authority. I'm in External Relations Division in a team that includes community partners, the Community Partner Outreach Program, and innovator agents. And Rebecca Donnell, my colleague who is an innovator agent, is going to go over this slide for you. Rebecca, are you here?
I'm here.
Mm-hmm.
Good afternoon, everyone. I'm Rebecca Donnell. I use she, her pronouns. And as Ellen explained, I'm an innovator agent. I've been with the state for almost 3 years. I've supported a variety of coordinated care organizations during that time. Pacific Source in Central Oregon, the Gorge, Marion County, and Lane County. Trillium in Lane County and the Portland metro area. And now I'm assigned to Health Share of Oregon. So I've seen a lot of different models of coordinated care organizations around the state. And so I'm happy to be with you this afternoon to tell you a little bit more about coordinated care organizations. So as Ellen mentioned, back in 2012, 2013, when the Affordable Care Act was introduced, the Oregon legislature passed Senate Bill 1580 that created coordinated care organizations, and they're our version of the federal accountable care organization. We call them coordinated care organizations because, exactly as Cheryl underscored, there's an emphasis on making sure that people have coordinated care, particularly those that have lots of needs, people who have complex care needs, etc. They're also intended to be providing integrated care. So not just physical care, they're not just a physical health plan, but they're really responsible for integrating behavioral health, mental health, and dental care as part of a full care package to those under the Oregon Health Plan. They are fully responsible for their members that are assigned to them within their region for the Oregon Medicaid program and the package of benefits that are covered under the Oregon Health Plan. Today, there are 16 coordinated care organizations serving Oregon Health Plan members around Oregon. They are intended to be localized as well. That's another distinction about the Oregon model, is that they're intended to work locally in their communities through their community investments and working with their community advisory boards. They should be understanding the community health needs locally and making investments, community benefit and community health investments with community-based organizations supporting their members and the community at large. 90% of Oregon Health Plan members are enrolled in coordinated care organizations. There's about 10% that are in fee-for-service, which is managed by the state. And tribal Oregon Health Plan members have the option to be enrolled in a CCO or be enrolled in fee-for-service. Clients who have primary insurance but also have Oregon Health Plan secondary must be in fee-for-service, and they're not in a CCO. So those are a couple of distinctions. I'll pause there and see if there's any questions around what coordinated care organizations are, or how the enrollment in coordinated care across the state looks.
And here is the map of across the state for you.
Oh, fantastic.
I hope it's the most current one, and it's a little blurry, so my apologies.
Yeah,
And
so you can see that there's much of the coordinated care across the state is fairly localized, but then if you look at Eastern Oregon, we have an innovator agent, Yami, who serves all of the Orange counties on the eastern side, which are supported through Eastern Oregon coordinated care organizations. So a large, expansive area on the eastern side of the state with a single CCO serving that area. And so pretty different representation in terms of where CCOs are delivering services and what that looks like for their communities across the state.
There's a question in the chat. Are the participants who are on a fee-for-service basis are offered a sliding scale option for payment?
So anyone who's enrolled in the Oregon Health Plan that's receiving services does not pay for services. So they should not be being billed for services that are covered under the Oregon Health Plan that they're receiving through fee-for-service or through their coordinated care organization. Any other questions?
Not that I
So
see.
if you know of someone who is getting billed, that's something to flag, to bring to either your innovator agent, and I'll tell you a little bit more about the innovator agent role here in a second, or the Ombuds program. We really want to know if something like that is happening.
And Rebecca, can I ask for you to hold the innovator agent role till we get to the Ombud slides, and we'll come back there. And here we have questions. So anybody else have questions here? I think what Rebecca shared is so important to hear. If you have clients who are getting billed for OHP covered services, which includes medically necessary and medically appropriate formula, we need to know about those cases. We're going to offer 2 different direct lines to client services teams, including our own, the Ombuds team, later on in this, but nobody should be paying for OHP covered services. Anything.
Okay, so I think there is time later on for me to tell you about the innovator agent team and what we do and how you can partner with us. If you have more questions specific to OHP, coordinated care organizations, any of that, put them in the chat and I'll try to answer them as Ellen continues with the presentation.
Thank you, Rebecca.
Thank you. And this slide is for me before we transition back over to Ellen. So what is the meaning of EPSDT for dietitians? And so it's probably the biggest, greatest thing that has happened for nutrition services and dietitians with the Medicaid population. It provides more opportunities for dietitians to bill for their services. And I want to be real clear here in terms of WIC does not bill for services. So for those of you who are working full-time in WIC, that this would be information, but doesn't necessarily apply to you because you are being paid by your agency to provide full-time RD services within WIC. But for those who are working part-time in WIC, who may contract services elsewhere, who might come into a work setting that they also have primary care settings, Salud being one, Benton County. There are a lot of agencies that have what is called federally qualified health centers that would be able to have a dietitian working in their primary care site and be able to bill for services. And so EPSDT is that billing for basically it's expanded Medicaid for children under the age of 21 at this time, soon to be going up to age 26. So we want to be thinking about how if you're interested in working in the area. So for an example, in some states, dietitians working in early intervention or working with the Educational Service District, the ESDs, doing home visiting. Those are all avenues of dietitians working in the community that would follow the billing, being able to provide those services under EPSDT. So what you would need to have are these 4 steps that we have in here regarding obtaining your licensure, because you have to, in order to bill, you have to be licensed in Oregon, and then getting your National Provider Identifier, your NPI, and then becoming having that same provider identifier under the Oregon Health Plan. And then at this time, wherever you're working within a CCO, individual CCOs would need to have you be credentialed. So all these links are live links that when they come out in the PDF, you'll be able to explore more. So as Ellen mentioned prior, that Oregon likes to apply for Medicaid waivers and to do a lot of experimenting. So EPSDT was partially in effect prior to January 1st, with that prioritized list of what is covered or not covered, oftentimes nutrition services did not meet that required line. So if it was below the line, oftentimes there would be like an automatic denial and it didn't even get explored. But now with this, that the T and the treatment, they need to require treatment to be offered. And if it is a denied service, they have to review it to understand why it was denied. So next slide. Highlights how and what WIC has been doing with Medicaid and why, how we got to this point. Believe it or not, even though we just recently had a government threat of a government shutdown, that happened 2013, many years ago. And we had a discussion with our partners in Medicaid of what's going to happen to participants who are on tube feeding and receiving formula from WIC. And we recognized that we were in a very vulnerable situation since WIC is not an entitlement program and that we are subjected to funding dramas that play out in Congress. So at that time, our Medicaid partners agreed to move medical formulas being provided by tube feeding over to Medicaid. In 2015, USDA sent out a memo saying Medicaid is the primary payer of medical formulas and that each state WIC needs to work with their teams at the state level to coordinate care with Medicaid in order to get Medicaid to be the primary payer. In 2016, as we were rolling out EWIC, the CDRC clinic, the metabolic clinic, didn't want to go with a standardized device. Who can blame them? They felt like we're ready to try to build Medicaid for the formulas that we provide, because WIC was providing metabolic formulas up until that time. And that was totally successful. We haven't had any issues or problems with metabolic formulas being covered by Medicaid, and CDRC takes care of those for the region. 2017, 18, we had successes in the non-emergent medical transport, which I know we're still working out some of the bugs on. And then 2018 was the Medicaid coverage for lactation services. And our team was really proactive of working to get legislation covered for lactation services. And then that's where we landed in 2023 and why this conversation has really taken a stride. And I want to do a shout out to our partners of elevating this conversation between the innovator agents, our team members on the Ombuds team, as well as on the Health Services Division. It really has escalated and we're doing great. We have a comment in there saying that we're still the only state that has, oh, Julie Reeder has joined us. I thought she was on another call. We are the only state in the nation that provides non-emergent medical transport for WIC visits. So that's huge. So great strides have been made and there's more to come. So what does EPSDT mean for Oregon WIC? It's any non-bid formula. So that's any of our formula that is not the Similac products, the Advance, the Isomil, the Total Comfort, the Sensitive, that is medically necessary and appropriate, is a covered benefit under Medicaid and required by EPSDT. We know that with that, we need coordination of care to be required to ensure that we make this transition. We recognize now that going back, there was many messaging that was happening for really understandable situations, because there was written into the Oregon Administrative Rules, essentially, they could have just said this, go to WIC for formula. And as we all know, we are so much more than formula, and we want to provide the preventative nutrition that WIC is known for, in having the dietitians spend their time coordinating care with teams that provide the medical nutrition therapy. And so that what EPSDT requires is that any medical necessary formulas be provided by Medicaid through the CCO or the fee-for-service program, depending on the participant's enrollment. So I'll pause here. Actually, I'll hold off on Anna Delia's question. And we'll go into, so Anna Delia, I'll circle back around to it, and hopefully Julie Reeder can provide some information on language services in the chat as well. So we did some data research to look at what are we issuing in terms of medical formulas, with the definition being we pulled out all of the bid formulas and looked at in 2 different months, with the most recently in October. What are we issuing? So it's 1,580 medical formulas were issued by Oregon WIC in October. Of those, the majority went to infants and children, 895 to infants, 57%, and 642 to children, 41%. As we know, for women, it's primarily like it might be Insure Plus, but it's really minimal. And of those formulas for the infants and children, 60% were really kind of dialed down into food sensitivity. So the partially hydrolyzed formulas, Elemento, Nutramigen, and then the preemie discharge formulas, Infocare, NeoSure. And of that, what I wanted to, I looked at the data in terms of where does it fall out? Is it more the metro area, or each county, with the exception, I think, of 1 or 2, maybe Gillum, didn't have any issuance of medical formulas during that month. But our top 5 agencies in terms of caseload being Jackson, Salud, Washington County, Lane County, and Multnomah County, they comprise 48% of the formulas being issued. And what was a little bit striking is that we're not talking big numbers here in terms of your total caseload. For most everyone, it stayed under 2%. Lane County was a bit of an outlier with 5.5% were formulas being medical formulas in that agency. So you do kind of wonder, do we have some work to be done with that particular CCO to just get the communication out of how to cover the formulas? I'll go a couple more slides and then we'll pause on that. So as we're having the discussion and recognizing that WIC being supplemental, we really need to have the discussion with our participants of what are their rights as being part of the Oregon Health Plan. And they do need to know that they have a right to medical formula that is medically necessary and appropriate, and that this is a covered benefit of OHP. They have the right to know that WIC is supplemental, and due to restraints that we have on federal regulations, that oftentimes we're unable to provide the full benefit that Medicaid must provide. And if Medicaid does not provide that, the families deserve and should be given a written denial known as a Notice of Adverse Benefit Decision, or NOABD, so many acronyms, from their CCO or fee-for-service program if a medical formula is denied. So when you hear from a family that they can't get a formula, oftentimes that is that denial, and that then we would want to know where they provided a written denial of provision. And then they do also have a right to access either through the Client Services Unit or the Oregon Health Authority Ombuds Program, who Ellen is with. They have the right to be able to access those programs for support. The Ombuds Program is statutorily directed to serve as advocates for those who receive OHP and Medicaid. They're there to help solve where systems might have broken down. And that's what I have just come to really appreciate about the Ombuds team. So I'm going to pause there because that was a lot to share with you. Any questions or comments about it? So far we have covered EPSDT and its opportunities for dietitian services. We've covered the coverage of medical formulas, timeline, and coordination between our programs, and the rights of our participants. Any questions about that?
Cheryl, this is Sarah Saul from the IDD Crashing Your
Hey,
Party.
our
Thanks
clinical
for the
partner.
invite. Yeah, so I think the question that's going through my mind right now is you talked about, the omission of the medical, like the metabolic formulas from WIC services. And maybe I'm looking too far into the future, but is there a movement that all of the medical formulas would fall more through this program and not be a part of WIC, or unclear?
Sarah, it's a great question. Many programs, including our neighboring programs in Washington State and California, do just that. They limit their formulary, and it does cause a bit of a delay for families in terms of access. And so that I don't expect any of this to happen overnight in terms of changes, that this will be a slow process that hopefully WIC's dietitians won't even notice what is happening, because it'll just be a slow decrease from the clinical side, from your team at the CDRC feeding clinic, that you would just know to do a prior authorization or reach out to a pharmacy or a durable medical equipment vendor such as Aviana, who's also on the call. What we don't want to have happen, and what we've really valued all these years, Sarah, as you know, working in Washington County WIC, is we never want to hold our families in an awkward situation where they don't have the formula to feed their infants or children. So that may be a choice down the road, as things just kind of, that we don't give out as much, let's say Similac 60/40 PM, a renal formula. We've already seen that kind of decline. So if we start to see more of the Infocare or NeoSure decline, we could look at that. But I think it's more that we just don't have the load that we do, that WIC is there as a safety net program, like we should be, but we are not necessarily the providers of medical nutrition therapy and formulas, if that makes sense. Jennifer asks, are we moving towards having Medicaid cover medical formula versus WIC providing? Great question. I'm going to ask that you hold that, Jennifer, because we do, that is coming up later in the presentation. And I'll review other questions that's coming through. But right now, I'll pass it back over to Ellen to cover and explain the Ombuds program.
Thank you, Cheryl. And I just have to say how privileged I am to have been brought into the WIC fold. What you do for our infants and vulnerable families is just phenomenal. That's what I've learned. And I think the collaboration that we're starting to build to ensure the ongoing care and the appropriate payer for the formula that our infants and children are receiving is really an important conversation going forward. So I'm going to talk about the Ombuds program. And can we have the next slide, please? I'm going to go over its history and purpose, who we are, who we serve, how you might come to use us or rely on us or call us or reach out. I'm going to go over a little bit of client services unit and introduce Julia Campbell, one of our client services unit leads, who's on the phone call today. And Rebecca can also come back and share a little bit about how you might want to engage the innovator agents for your CCOs. Next slide, please. So as Cheryl indicated, the Oregon Health Authority Ombuds program was is legislatively mandated to serve as advocates for people who receive Medicaid and Oregon Health Plan. This is Not all ombuds programs are created to be advocates for those they serve. Some are created just to basically ensure fair process. We are obligated to be advocates. We report to the governor and the Oregon Health Policy Board quarterly. Our reports are online. This is another obligation, by the way, that we report quarterly. Our last two reports have really focused on behavioral health. Our year-end 2022 report on behavioral health challenges for adults and our 6-month 2023 report on behavioral health challenges and improvement recommendations for children. Next slide, please. This is our legislative guiding statute, and just so you know, when a client gets, this is not the same thing as when a client is denied. So, but when a client files a complaint like, hey, I couldn't find a provider to see me, the CCO is obligated to send a letter, a complaint resolution letter that indicates that the client can reach out to both the Ombuds program or client services unit if they are dissatisfied with the response. And of course, we have the right and sometimes have to use it to ask the CCO to share any documents that they have related to the cases that come to our attention. Yeah, next slide, please. Oh, we went straight there.
I was Joe, did not mean to.
That's no worries.
Okay.
No worries.
Careful where you click. There you go.
So ombuds, you know, we call it, I get so many clients who say, what in the world does that mean? I can hardly pronounce it. I just say you can call me Buddy for short, but here are some in other languages, how ombuds is translated. My favorite one isn't on this slide actually, and it's an African language, I think Amharic, and it translates into keeper of the people's tears. Next slide, please. Who are we here to help? 1 in 4 Oregonians, we've been through this, who have Medicaid or Oregon Health Plan. And I do want to say here that that includes people who are in residential treatment facilities, who might be getting in-home services and supports, which pretty much are paid for by the fee-for-service program. Next slide, please. And these are all actually true case stories that we get. I'm supposed to be able to get a ride to my doctor appointments. The driver did not pick me up on time. My doctor's office is going to drop me because I've missed so many appointments. This was 2 cases we had. I need detox, but the provider says there's a 6-week wait for OHP clients. I can drop OHP, prove I'm off OHP, and pay $26,000 out of pocket to get into detox. And more recently, OHP is denying my child formula that is essential for her health and well-being. Next slide, please. We work closely with the client services unit. As I said before, our office is in the external relations division, housed with the innovator agent team and the community partner outreach program. I think some of you probably work with that team. They have community partner collaboratives in every part of the state. We work with the Ombuds program, addresses probably about 200 and 250 cases a month. Client services unit, housed within health systems division, gets about 1,000 calls each day. And they help clients at every level of understanding and confusion learn more about how to access their benefits. We could not work without them. When you get your OHP ID as an OHP member, the first thing on that card, it says, if you have any questions, call CASU, which is 1-800-273-0557. We really are the last door, not the first door. That's why I'm so glad to have CASU here. And Julia, if you could just jump on and introduce yourself. This would be great time to do that. Julia is our, go ahead, Julia, just introduce yourself and talk a little bit about how wonderful you works.
Yeah, my name is Julia Campbell and I work for the Client Services Unit, Client Enrollment Services, as well as the Complaint Resolution Team. And what we really are is the OHP navigators. We help our members understand how to go ahead and access their services, how to speak with their providers, how to get bills resolved, how to change their access to care if they want to do that. But also to be able to be a voice for when they're having issues, or if we start to see more of a systemic problem, we start working with the ombuds really closely to try to figure out how we can better resolve their issues in a full resolution.
Thanks, Julia, and that's their contact information. You feel free if you have any cases you need questions about, and I think Cheryl's going to talk about a case example of a case we worked on. I do want to call out here that there's another incredible person on this phone call with me. And her name is Lacey John. I don't know if any of you worked with Kelly Jamison, but she was our durable medical equipment policy lead for many years. And it is just striking to me that for some reason, formula is considered a durable medical equipment, but that's where it mostly lives. Lacey works for Nathan Roberts, who is the reason, along with your WIC leads, that Oregon became the only state in the nation to provide an EMT for WIC clients. So Nathan also recruited and is supporting Lacey. John, if you want to just say hi, Lacey, that would be great, in her new role as our DME policy lead. Are you there, Lacey?
I'm here, Ellen. Thank you so much for that nice introduction.
All righty. Okay, next slide, please. And I do have some really good news, I think, Cheryl, about here's how you reach the Ombuds team, by the way. Thank you. And the good news I have relates to our rule, which currently says that inappropriately, according to federal law, by the way, I just want to repeat that. Our current rule, according to federal law, is inappropriate in that it calls out that WIC is the payer of first resort for a formula. WIC should never have been the payer of first resort. It should always have been Medicaid. And we need to change that rule. And I learned from Nathan this morning, WIC colleagues, that there's going to be a temp rule filed to change that language by the end of this year. At that point, a 6-month clock will start, at the end of which all of the rules in that book related to formula will have a review. There'll be racks. Anyone here interested can please reach out to me and say, really, I want to be involved with rules change. You're going to hear about it. I'll work through your WIC state leads to inform them. But I thought that was such great news that we're going to finally change that very confusing language that kind of allowed our CCOs and our fee-for-service program to look at rules and go, hey, not us. All of this has to go through WIC.
That is excellent news. Thank you, Ellen. And I will address Julia's question that we have in the chat as well. But let's see, next slide. Okay, well, let's stay on together and talk about the Cape Farms situation. So this is one case study. Beth and I have probably worked with many of you regarding different cases that have come up over the years from the letters that we used to write about WIC cannot provide, or we'd have to justify how much WIC could provide. We don't see those letters as much anymore, but we do see situations like this that came up. Cape Farms is can't call it necessarily a blenderized food. It's a little bit different than that, but it's in that same kind of category where it is a whole food, which of course it's a great product, especially for individuals on tube feeding, and they respond very well to this product. So, and I want to rely on, because I do not want to misrepresent any dietitians in Deschutes County, but I did vet this by them that, and this is often how it works, is that a WIC dietitian in a local agency is contacted by a clinical dietitian stating that WIC needs to provide X formula. And in this case, it was Cape Farms formula. And it's a formula that's not on our formulary. So then Deschutes County reaches out to the state WIC office. And because of the work that we've been doing recently, I knew to like, hey, Ellen, and credit goes out to Julie Reeder. Julie connected us, and it was just, it changed everything. So Ellen and her team worked. Go ahead, Ellen, you take it from here because it's your work.
So what we did was ask the folks on who, when you have a relationship, as the primary care provider did in this case with the CCO, I said, did you submit a PA request to the CCO? And the answer was yes. And there had been a denial. And from Lacey John's predecessor, Kelly Jameson, as an ombuds, you must encourage clients to appeal and request a hearing, but I knew that that was going to take too much time and that the CCO just needed to be encouraged to take a look again at their denial. And from Kelly Jameson, I got language that said EPSDT requires the CCO and fee-for-service to provide formula that is medically necessary and medically appropriate. This formula seems to meet that in this case for this client, based on what I'm reading. This formula meets that criteria. And I sent that to the CCO. The CCO immediately said, oh my goodness, we didn't know. We're going to A, that's one thing they said. B, we're going to have to re-review all the denials we gave about related to this formula. And C, while we figure out where to get this formula, which is another issue that maybe someday we can discuss, while we figure out how to get this formula, we're going to use flex funds. Can we use flex funds to provide formula in the meantime? As a result of that case, our flex fund program, which is called HRSF, Health Related Services, said that for any CCO in the fee-for-service program, they can in fact use flex funds to provide medically necessary and medically appropriate formula in the interim while the CCO is making a decision, I should say, not fee-for-service, while the CCO is making a decision about whether or not to formally provide the formula. But I'm believing that with this rules change and the education that Nathan Roberts and his team will be doing to the CCOs about the rules change, we're not going to see a bunch of these denials anymore.
And that's great news. And that is one thing that Sarah Saul brought up, that she sees in the clinical setting that we hear oftentimes is that it would get denied. And we also know that on the vendor side for Aviana being one of them, the durable medical equipment vendors, for some reason, they are not prioritized to get formula over WIC. So there are times that WIC can provide formulas and get it out to the families through Formula Warehouse. So that's for those of you who are joining as guests, that's a home delivery service that WIC has set up with the DME side, the intro side of Providence Health Systems. To complicate things, and I'm sure a lot of the dietitians in this group can empathize with is there was a language barrier for this family. So there was just so many things that it just lingered and was going on, and it just helped to be able to have the resources like with the ombuds team to just cut through and just say, how do we make this work? And it cut through a lot of red tape. So it just, thank you.
Can I say two other things? And
Oh,
I
of
wish we
course.
had thought to put it on our client rights. One of the rights clients have, and we've referred to it, but particularly your clients, WIC nutritionists, is care coordination. And when we've raised this issue with CCOs, like we're hearing that WIC is the first payer, they shouldn't be. We're going to start sending you cases where you might want to think about providing formula that for these infants. But the other thing in CCOs we've already started meeting with several, and this is where Rebecca Donnell's work is going to be so valuable because innovator agents can help connect these dots as well. The CCOs will provide care coordination, and that's what happened in this case. in Deschutes County. The CCO said, we are going to provide a care coordinator for this client and make sure that they're getting all the services that they need. And before I let Rebecca just jump in here, I want to comment on the language access issue, and thank you for raising the question. And Adelia, I might have gotten your name pronounced wrong. I do not know about CCO fee-for-service obligation to cover language at WIC appointments. That's a very good question. I'm happy to find out about it. I suspect WIC is obligated to provide language services. Is that correct? Anybody?
I was
from
going
WIC?
to say that, Ellen, that I don't think, because we're not billing, we don't bill for that appointment. I don't know how we bill for a language aspect of that.
That's a very good question then. Thank you, Julie. We'll come
Yeah,
back
we
to
can
that.
keep looking into it, but it seems very challenging because that's
Yeah.
it's not a billable visit. So it seems very hard to bill for, language services. Thanks.
Thank you, Anna Delia, and thank you, Rebecca.
Thank you, Ellen. I just want to give a shout out to the OMSPUDS team and the client services unit. I think of them as sibling departments or units with the innovator agent team, very complementary divisions under the external relations and HSD larger families, and we do work closely all of the time. So I'm just going to quickly, I don't have a slide, but just give you an overview of how we can help support issues that become clearly systems problems. They aren't an individual case. They aren't something that is a one-off issue that happened because something fell through the cracks with the CCO, or it was a complicated case that needed to be looked at further. Those are sort of one situation where client services might have provided the person initial information. They still got denied by the CCO, and then the OMSPUDS team comes in and works with that person or family and helps them get their situation resolved, hopefully for a positive outcome. We have a team of innovator agents. We are also statutorily directed and required to work with our coordinated care organizations on behalf of Oregon Health Plan members. Our role is a little bit different. OMSPUDS work with individuals and families around specific cases that are challenging, that they really need an advocate, a one-on-one advocate, that person to be the voice for them with the CCO to really get to the bottom of what's going on in their specific case. Innovator agents come into play when you're working with a CCO. Let's say that the EPDST benefit is not being implemented correctly within the CCO in your area, and you know it because you've seen several cases. You see a systems problem where the benefit is not being applied as it's intended. You need some help to get this resolved with the coordinated care organization. That's where your innovator agent comes into play. We can help work through those systems level issues, how benefits are being applied. We can work hand in hand with an OMSPUDS while they're working on an individual case that represents sort of a systems issue. We'll work on the systems issue while the OMSPUDS will continue to work on the individual case to see it come to resolution. Some of these things are complex, and NEMT is a great example of something where OMSPUDS and innovator agents worked diligently on a lot of systematic issues, still are doing that. So we can really work hand in hand to support you. We're not a gatekeeper to the CCOs. We'd love to get folks connected to the right people within the CCOs to be able to talk to directly. Oftentimes, though, we can really cut through the matrix of an organization, the matrix of a CCO. They're large, complicated organizations that you want to get to the person you need to talk to. So we're really good, and we can hold them accountable. So if they committed to getting back to you on, why something hasn't been covered, you gave them 4 cases to look into and want some understanding of what happened with the billing, we can hold them accountable and make sure that they're following through and that they're committed to providing the benefits for members in the way they're intended to be. And so there's a team of innovator agents. We are assigned to various CCOs across the state, so that you have an individual within your area that you can contact with any questions related to how a CCO is providing benefits to members and getting support for that. So I dropped in the chat our information. It's a website with all of our assignments and our contact information. Feel free to reach out to us. In a nutshell, I would say client services, like Ellen was saying, is getting 1,000 calls a day. They're helping people quickly try to navigate through, getting a question answered around their benefits or working with their CCO. OMSBUDS, it's working one-on-one with individuals and families through really complex cases most times, and really trying to get to the bottom of why decisions were made on the CCO side and holding them accountable. And we can be the partner on the systems level issues to see change that is broader and more systematic and hopefully resolves larger problems, so that they don't continue unaddressed. And
Thank you,
so
Rebecca.
individual
Rebecca.
cases keep happening. Yeah,
Yeah.
thank you.
And thank you for putting the link in there. I want to do a shout out to the innovator agents, and one that is near and dear to Wick's heart is Belle Shepherd, who has worked in WIC settings in Southern Oregon, and has worked really closely with us to kind of look at some of the processes and where we can make some improvements. Just want to reassure the WIC dietitians that contacting your nutrition consultant at the state can help elevate systems problems. There's nothing that you are expected to take on yourself. As it has taken me 15 years to get to this point, so it's very confusing, and there's a lot to unravel. But we're hoping to just put more tools in your toolkit. Having said that, we recognize that this work is not going to happen overnight. This slide highlights the challenges that we have uncovered in our discussions with our partners. And we're all working on the premise that coordinated care organizations want to do the right thing for their clients. And a very basic problem that we recognize is the governing rules that the CCOs have been following all these years, and that is what's called the Oregon Administrative Rules. They are incorrect. And so the one at the very first bullet, you'll see Oregon Administrative Rule 410-148-0100, which states reimbursement will not be made for the following: oral infant formula that is available through the Women's, Infant, and Children program, WIC program. So we have called this out over the years, but for various reasons, it has not gotten to the level which Ellen just shared out to you, where we have Nathan Roberts, who will be working on this to get something done. And within the next 2 years, we'll start to see a little bit of movement. I'm sorry, Jim. Oregon falls under the, I believe what you're asking is which regulatory system that drives the statement. This particular Oregon administrative rule falls under EPIV, which is the enteral and parental IV services, which is a bit confusing in and of itself of where WIC lies within Oregon administrative rules. We all know that Medicaid, we're required to refer to Medicaid Medicaid is also required federally to refer to WIC. And so we don't have just basic language in the Oregon administrative rules other than this particular one. So we have work to do to build, there's many reasons that we want to have a reciprocatory relationship with CCOs, innovation being one, but formula is not really where we want to be called out in the Oregon administrative rules. So this will, go ahead. Okay. So we also recognize within the administrative rules, there is criteria for determining when a formula is medically necessary that is outdated. And Julie Reeder recently pointed out that the criteria that they have for infants is the same criteria that they have for someone who is 80 years old. Basically that diagnosis of failure to thrive and a certain amount of weight loss. And that just flies in direct conflict with what the EPSDT rules are, which was saying basically we want to be able to have a formula that is medically necessary and helps to ameliorate any of the conditions that the individual is experiencing. So there's room for improvement there. We know that reimbursement rates set by the Health Systems Division and each CCO is ridiculous. I think Jennifer Saunders shared with me that sometimes they're losing money on formula at the rate that they're getting reimbursed. So the reimbursement rates, and this is not just formula, this is across the board for a lot of different things within how organizations get reimbursed. We also know that access is a problem, as we talked about, that we should be prioritizing the organizations that are providing tube feeding supplies and medical formula, such as Aviana, that they need to have improved access to the formula, and they need to be able to provide that formula in such a way that it is financially viable for them. We don't know in terms of improved access right now. Pretty much the rules are written that it is a DME vendor, but why, if someone is needing Alimentum and they can take it by mouth, why can't they just go to a pharmacy? So we have some issues to work out there. And we also know that there are not systems in place on the Medicaid side like we have with Formula Warehouse. So they are wanting to meet with the Formula Warehouse to figure out how did they set up the system? Is it something that they could look at on that side? We want to do listening sessions with the durable medical equipment vendors to find out what is your experience? When have you had to turn people away because you're not getting reimbursed at a rate that's effective? And we know we need to improve communication and education on all fronts. So I see that Ellen turned on her mic, and I also want to open it up to either Jennifer or Allison from Aviana if they want to speak to their experience coming from a durable medical equipment vendor.
Hi there. Can everyone hear me okay?
Yeah, hi, Jennifer.
Hi. So my name is Jennifer. I'm a nurse with Aviana Healthcare, and I just wanted to hop on and be a part of this meeting because it's so nice to problem solve with you guys and, kind of commiserate about getting formula to our patients, whether that was enteral or oral. We are here for patients throughout the Oregon region with any types of insurance except for MODA right now. We're working on Cigna as well. But I think I just wanted to make myself available for you guys. Also, if there's any patients who are coming up on that 5-year mark, or if there's something that we can provide if a patient is needing more than WIC can provide, we can help you guys out with that. If it's just like, hey, let's provide 5 extra cans of something and try and get it approved by their insurance. But, Cheryl is correct. We're having issues with reimbursement rates for a lot of patients, for a lot of formulas. And so if for some reason we're checking benefits eligibility, and then we check with Oregon Medicaid and they don't reimburse us enough to cover the cost of the formula and shipping it out to the patient, we're essentially losing money by taking on that patient and have to, say no to the referral or send them on to another company that, isn't as strict as us and hasn't figured out that, I think it's hard right now. It's hard to say no to patients if their insurance won't reimburse well. So I also wanted to see if there was anyone out there that's in this meeting that's having any similar issues or has anything to add to that, or I don't know if there's any growing pains like that. It'd be nice to commiserate, but also problem solve this.
Jennifer, this is Sarah with the CDRC again, and I was actually starting to type. I've been so
Yay.
grateful over the years that Aviana has been amazing at helping to cover these oral nutrition supplements for kids who need them.
Yes.
And I understand that you can't lose money on things. So we're feeling tons of growing problems. And I think some of the some of the DMEs have been closing, some are not accepting new patients. And I think that all of these issues, like the slide that Cheryl has up right now, every single issue is so important and big and contributing to this sticky place that we're finding ourselves in. And that's part of the reason that I'm on today, is to try and say, well, if the DMEs can no longer take on this at a loss, what do we do? And it sounds like there's hopefully more education going out to the CCOs and primary care offices that can help us be our partners. But it's been tough, and I'm hopeful about all the information I'm learning today.
Yeah, we need the cases, we need the data. So it's more to come. And I think knowing and making these connections will be really critical. I saw that Julie had her hand up. Julie, did you?
I was just going to say that the timeliness too of being able to access this as well is one of the biggest things. Is, we could tell them, go to Walmart, go to this, different place to go pick it up, and they could be doing, driving around town if they have a vehicle to be able to find the right formula versus knowing where they will be able to access this. So I think that's the other thing that we need to work out is DME. When we work through that, some of them could be same day, next day, within 3 days. And then other places could be 5 to 7 days, which isn't reasonable for some of these requests or formulas that these individuals are going to need. So that's what I wanted to add.
Yep, we've got some growing pains, that's for sure. And Ellen, you've got your hand up?
Just quickly to make sure that folks saw what I put in chat. The fee-for-service program sets rates that must be a floor for the reimbursement rates that CCOs pay. When I raised the email that you sent me, I think yesterday, Cheryl, yesterday, to Nathan, he said, this is an easy fix. I mean, easy, but it really is about ensuring that people are able to get formula from vendors because the vendors are getting paid enough to offer it. And if we are having vendors lose money, we would expect what I hear Jennifer is saying. So Jennifer, I think it was you who provided that information. It was really helpful. Thank you. And we do have a lot of work to do. Yes, indeed. Thank you.
Well, it's getting scary because we're getting a ton of referrals from other DME companies that are closing because they can no longer provide oral nutrition. That it's just, they're like, that's not where the money is, or whatever their situation is, that either they're not getting reimbursed enough for it. So I understand that you have to say no to some people, but there's got to be a way that we can work with insurance companies to explain that to them. At the end of the day, let's just feed kids. Let's feed our children. It's just, I don't know. Cheryl and I just have rolled our eyes about this. So Yes.
Yeah. So lots of questions about reimbursement. It's not reimbursement. It's not based on someone being compliant. Insurance companies have to pay. The CCOs need to pay, but when there's a set rate that has not been adjusted, and that's what we're looking at, is that adjustment. So an action item that will be coming up is getting a listening session together of all of the DMEs that have in the past provided oral supplements that are getting out of the business, as well as Aviana, and then Lincare is still in the business of providing oral supplements, and we need to get this figured out. So that will be a priority ASAP. So it's all about just calling attention, and so that's why we need to know about it and to connect and support our families in it. So for those working in WIC, you're probably wondering, so what does this look like? Like, how does this impact me in my day, in my work life? And I want to just reassure you that it's going to look the same as it did yesterday. You may, over time, and when I say over time, probably 2 to 3 years, it's that slow, that you just might see a decrease in the number of requests for medical formulas. You just will see a decrease in medical documentation forms. The reason being for that is, as we get this information out and share it out with the specialty clinics, like the NICU clinics, the GI clinics, the renal clinics, there will be paperwork that will be started to provide the formula or to complete what they call the CCO prior authorization form. So that, Kathleen, is what happens behind the scenes. Someone will just write a clinical dietitian might write a prescription that goes to Aviana, and then Aviana is doing their due diligence to do the paperwork required for the specific CCO. And Jennifer has said, like, sometimes I just call customer service of the CCO to find out what form I use. So I did a study of the prior authorization process based on website information, and then Bell Shepherd has been providing some inside information of the CCOs, and we will send that out as we learn more. So Kathleen says, so what can we do again? Tell the participants to ask their doctor to send an authorization form for WIC to Aviana. So recognize, I want to go slow at this because we want to hold the families in the process of this. So WIC dietitians don't need to be doing the work of Medicaid. WIC dietitians do not need to be doing the work of Medicaid. So if you find out that like a certifier comes, they learn of a formula being provided by an outside source, we need to gather data. We need to put in progress notes. What is the formula? Where is it coming from? What's the name of the intro company? Whether or not we have a separate form that WIC wants to have them fill out to be able to coordinate care, that's what needs to be decided. So the questions to you all is, we know we need to get the OHP number. Do we add that to the WIC documentation form so that we have that and we get that into our system? We need that if we're going to coordinate care with the Ombuds program with the client services unit. The second part, do we create a new form or a cover sheet to assist with care coordination? And if so, do we, what would we include? Do we want a statement on there that the formula is medically necessary as a covered benefit of OHP? Do we have a checkbox for the healthcare providers? Like, did you attempt to obtain this formula from the CCO? Do you need WIC to provide it for 1 to 2 months while setting up the CCO process? Does a family understand that WIC is supplemental and may not be able to, whoops, sorry about that, provide the full amount? That's what got left off on that slide. What else do we see? What would help with doing your job? Because we don't want to be telling a family at this point in time, you can't come to WIC for this formula, because right now we are the best frontline access to formula. Jennifer. Hamilton.
Hi there, just a quick question. So I have had the opportunity to work in Washington State, and I'm just bringing from my experience there where they did have coordinated care. They had a separate form that was just for insurance purposes. So there was an option to say that WIC could provide X amount of cans and they're needing X amount more. This person is not on the WIC program and not eligible. And it just simple information. There was no diagnoses, but since they already have a form, it may be worthwhile to reach out to Washington State to see what they have and then kind of work off of that to create a Oregon form.
So from your experience, because I have that form, was that something that was easy to use as a WIC dietitian?
Yes, it was pretty easy to use. However, it would be good to have clarification again of kind of what the Oregon WIC role of is going to be in terms of providing formula. Because my understanding was that if insurance is covering it, then WIC could not cover it. But if that's going to be changing, then we obviously would need to be abreast of that information.
Thanks, Jennifer.
Mhm.
Others? Kathleen says, it sounds like the plan is to offload. Ooh, that makes me cringe a little onto local DME companies such as much as possible, since we only provide partial food packages. I'd like to flip that around, Kathleen, to just to share. I think it's our job to share with our families that WIC is supplemental, and that sometimes we can't provide the full amount, and that they do have a right to get the full benefit from OHP. Does that make sense?
Can I just jump in here to say, and I know Kathleen in Warm Springs, you were the one who raised appropriately tribal members. About half tribal members choose fee for service for their plan, but and I'll come back to that. But 90% of our clients are enrolled in a CCO. And as a dietitian who's on the front line serving these clients, it is to your advantage and the CCO's advantage to help them know who those clients are that you are serving as a WIC dietitian who need medically necessary and medically appropriate formula. The CCO is the one who is obligated to develop contracts with any one of their subcontractors, including durable medical equipment suppliers. And it is up to the CCO to ensure that their members have access to the formula they need. So although I said the fee-for-service program sets the floor for reimbursement rates, which is true, CCOs can always offer more. This is more about making sure that the CCO knows when they have, and your help is so critical here, to help find out what CCO the plan is in. I can't tell you how many times I've heard this, but my client was denied. Do you know what CCO the client's in? No, I just know they were denied. You have to know the CCO so you know who to reach out to, or if it's fee for service. And I'm sure you know, Kathleen, about the Tribal Care Coordination Program, which is run through Care Oregon and can help. I mean, it is kind of the counterpart to care coordination for tribal members who have fee for service, the counterpart to the care coordination provided by CCOs. I hope that helps.
Thanks, Ellen. So in summary, the next steps for the state WIC team would be to continue the work that we're doing on the systems change that Rebecca mentioned, to work with Medicaid partners, to change the Oregon administrative rules, to clarify that Medicaid is the primary payer of medical formulas, not WIC, to do resource development with input from all of you, and to work with the innovator agents and the CCOs to make sure that the correct messaging about WIC is provided to medical providers, families, and partners. Autumn says that the CCO in her area pretty much sticks closely to the prioritized list of services. And are we likely to see participants denied medically necessary formula because of the OARs? So what EPSDT does is that prioritized list stays in effect, Autumn, but it says we need to look at and evaluate each individual one. We can't just do a blanket denial any longer. And then, yeah, you are catching on how we're defining medically necessary formula. That needs to be worked out as well. Pediasure, in some instances, probably may not cut it in terms of medically necessary, but preemie discharge formulas, absolutely. Yeah. So you can see where some of the 60, if you think back on that slide that says 60% of the infants and children's formulas were partially hydrolyzed, and the preemie formulas, that's probably where it's going to start. Well, we'll just see a diminished amount. So the next steps for local agencies, we just keep doing what we're doing because we have not changed policy. So step number one, you follow policy. And I hope that helps, Kathleen, to just say that we haven't changed any policy at this point. We're just giving you tools and making you aware that EPSDT has changed the landscape. We do encourage you to decrease the number of medical documentation forms initiated by WIC. We know for a lot of reasons that's a practice that has contributed to where we're at and will need to change when we go into a new data system. Please reach out to your nutrition consultant when you hear a family report that a Medicaid is not providing formula for tube feedings, or if you're redoing a review of charts and you see that WIC is providing a medical formula for a tube fed individual. That needs to get moved over absolutely to a CCO as soon as possible. So we need to get working on those. And if we need to hear about Medicaid denials, and we need to gather information that is helpful for the ombuds team and also the client services team. They'll need to know the OHP number, the name of the CCO, and who is the name of the DME. If there is one, the DME supplier. Anything to add on that one, Ellen?
Oh, no, I could have just shook my head. No, there's nothing to add except that it is really hard to know who to reach out to. When I get a client who needs a service, I am reaching directly out to the CCO, and the CCO is going to want to assign a care coordinator, which is a huge advantage for our clients. And a good care coordinator will engage their WIC counterpart if WIC is already on the kind of the front lines with that member. So care coordinators sometimes are just navigating with others who are already there for members.
So, Ellen, how can we help local agency dietitians connect with care coordinators within a CCO?
What we are learning, and this is where Rebecca and the innovator agents are coming in helpful, but we are learning on a CCO by CCO basis how they would like, how each CCO wants that connection to be made. So yesterday I sent you information for Jackson Care Connect and Columbia Pacific CCO. And we are gathering information from others. And so for each program, it will be different. It's the same for Ombuds program. I'm just going to put that out there. We do not have a cookie cutter model for reaching any one of our CCOs. We talk to each CCO about what they want, and we go through the door that they make open for us. They would, in all cases, consider these kinds of situations urgent, emergent, and be looking forward to supporting you to get the right formula to these infants.
And you'll see that in the chat, Kathleen has said, what do we do for participants who need medical formula but can't afford to purchase it? We can still do a medical documentation, but there are times where families are paying out of pocket, and we know that it's a covered benefit. So we need to encourage them, work with the provider to fill out an authorization form. And whether it's a DME that's providing, that's the current practice right now. It may be that pharmacies down the road are the ones who are providing it. So that will be more information to come as well. But yeah, we need to hear about those situations. Sarah Saul says, we're talking a lot about formula provided by WIC and DME. Aren't we also able to send to pharmacy and go through the same process? That's what we're trying to figure out, Sarah. If it's oral reimbursement is low for DME. I think what we're going to find is similar to what we found in WIC when we went to a pharmacy, that there's a lot of reasons that they don't provide it. I don't know, similar to what Aviana is experiencing, whether it's because they go through McKesson, which is a secondary provider, whether they just don't have access to it. But we do have access issues, and we know we're having some problems. Yeah, no, it's a problem. Anything that you kind of wonder, like, why is this crazy making? It's probably very likely to be true. We have access problems, we have reimbursement problems, we have process problems. So
yeah, this is Rebecca Donnell. I put in the chat that behind the scenes with Bell Shepherd providing you with a report about how each CCO handles prior authorizations, what DME providers they're working with and are contracted with, what their processes for care coordination. Each innovator agent is working with their CCO to follow up on those questions, to compile that information for you so that you have more detailed information to be able, because each CCO does work very differently. That's why I have a job.
yeah,
To be frank, that each
yeah.
CCO does things differently, and hence the reason for an innovator agent to some degree is to help figure out exactly how to navigate that CCO's processes.
Right. And correct the processes, because some are just incorrect based on what they have in terms of
that's right.
Yeah. So
yeah. So the more information you can gather to show where things are not going correctly, we can work with others within the state to figure out the right solutions, whether it's at the CCO level, at the administrative rules level, at the reimbursement level, whatever that is. So
can I just add here, I think I forget, I'm off mute, that in a meeting with HealthShare the other day, because HealthShare has a number of plans within it, they said, we don't have a PA requirement for a formula. We've never heard of this issue. And my guess is because nobody's asked them to provide it.
right.
So they don't even have a PA process for formula. I want to repeat that. And I also want to say that we pay the CCOs a whole lot of money, and it's their obligation to provide medically necessary and medically appropriate care and services to their clients. This is not about leaning on the DME vendors exclusively or pharmacies. It's about going to the CCO and saying, what are you going to do to get access to this formula? And especially for Kathleen at Warm Springs, fee-for-service is very different than CCOs, but also has that obligation and wants to know when there's problems. It's a different door, though, as I think Kathleen would probably know. Thank you.
Thank you. And I know that we're reaching right up to the hour. And we just want to say thank you that you are coming off of a formula recall and shortages, and that we're gathering more tools and supports, and we'll get those out to you as they evolve and happen. Change does take time, but we're moving in the right direction. And we have resources just as for all the programs that we listed out in the session. And here are the contacts for the Health Systems Division, the Ombuds team, EPSDT state team, and know that you can start with the state team at WIC if you're kind of wondering which way should we go. So more information will be shared out, and we hope that down the road that we have a better coordination between the CCO care coordinators and the WIC dietitians for you to help to navigate how to do the best for your participants. And I'll stop sharing my screen. And I want to thank Ellen and Rebecca, our partners that joined us, Sarah and Jennifer, and I know Allison was on on as well today. We will be continuing to do the work to get this laid out. And let us know when you hear of just any strange cases or you're just wondering questions, please just keep them coming. We'll test out any forms that we suggested. And Jennifer Hamilton will look at the Washington State one and get that sent out and kind of adapt it to Oregon and see how it works. So more to come. And I think, thank you, all of you, for joining today as we uncover, like lifting up rocks and seeing what we find underneath, but it's all good stuff. Thank you. Take care, everybody.
Thank you for a wonderful presentation.
Thank you. Appreciate it.